first case I have selected is a 70-year-old gentleman. He had cardiac arrest following maybe acute coronary syndrome. He attained return of spontaneous circulation after 4 minutes of CPR. Now he is intubated with the 7.5 millimeters internal diameter cuffed endotracheal tube. You look at his vitals. His heart rate is 70 beats per minute. ECG rhythm is showing sinus rhythm with occasional ectopics. Blood pressure is maintained around 110 by 70 millimeters of mercury, and saturation SpO2 hovering around 90 to 92%. Presently, he is being ventilated with a bag valve device with oxygen supplementation by your colleague. How do you connect him to the ventilator, and how do you get the ventilator ready for him? So initial ventilator settings depends on whether the patient is passive or paralyzed. In this case, the patient is passive, and right now he is hemodynamically stable. Oxygenation, whether it is satisfactory, we are trying to take the patient to cath lab for a coronary intervention. So he will be in a control mode ventilation or with paralyzed mechanical ventilation for some time at least. And it all depends on whether he has any more comorbids, and depends on what exactly is your immediate target. Okay, whether it is maintaining ventilation for some time, or you are planning for some elective ventilation for some time till the primary pathology settles down. So you get the ventilator ready, power it on, see that system check is done. It all depends on the technical support you get in your intensive care unit. But from your side, you start doing the patient setup. You can select new patient and then give whether it is an adult patient, child or infant. Okay. Again, you have to fill in the demographic profile like gender, height in centimeters, and weight either in kilograms or pounds depending on the make of the ventilator. Modern day ventilators will give you these values: body surface area, ideal body weight, and some even suggest tidal volume to you. Okay, now you are going to set the ventilator, and for this particular case I'll be describing one set of initial settings. You don't ask me whether some other setting is okay or not, but there are a good number of combinations possible. There is no absolute one single best initial setting. So in this case, I am going to opt for assist control pressure control ventilation. Okay. First, I am planning to start with an FiO2 of 100%. I'll come down on FiO2 depending on the either the blood gas values or the oxygen saturation on the monitor if the pleth is satisfactory. Empirically, I am trying to set an inspiratory pressure or pressure control, as we call in some ventilators, as 10 centimeters of water. I'm going to set a PEEP of 8. Usually we set around 3 to 5 centimeters of water, which we usually think about as a physiological PEEP, that positive pressure ventilation, we keep usually a minimum of 5 centimeters of water. In this case, I would like to go a little bit higher because I suspect the patient is in pulmonary edema following heart failure. Okay, breath rate of 14 should be sufficient, and I ratio 1:2 I'll go with. And for safety, I'll keep a pressure limit or P max of 40, because in any case, the circuit pressure, the system pressure will not go beyond 40. So plus the other synchrony factors we'll discuss about trigger and all little later, but as of now I'll keep the same flow trigger of 2, and then depending on the make of your ventilator you can opt for this tube compensation, assist control leak compensation, etc. These are depending on the manufacturer's instructions. Okay, after having set, you connect the endotracheal tube to the breathing circuit of the ventilator, and then look at the monitor. What all values are shown in the picture. The set values and monitored parameters are different. How much it can be different, we'll see. So this monitor is showing a FiO2 of 80%. I have reduced the FiO2 from 100 to 80% already. The PEEP of 8. The peak pressure is showing as 18. Minute volume is 4.8, and look at the tidal volume is 239. which I think is slightly low for this case. Okay. Then how do I set the tidal volume and rate? For normal lungs, you can set an initial tidal volume of around 5 to 7 mLs per kg, and you can set a rate of somewhere between 10 to 20 breaths per minute. Suppose you are dealing with a chronic obstructive pulmonary disease or asthma, you can have an initial tidal volume of around even 8 to 10 mLs per kg, but the rate should be less, somewhere around 10 to 12 breaths per minute. In patients with chronic or acute restrictive disease like pulmonary fibrosis or acute respiratory distress syndrome, you need to go for further lower tidal volume of around maybe 4 to 6 mLs per kg with a rate of 15 to 25 breaths per minute, depending on the case. Don't take this as a one-size-fits-for-all recipe for all the cases. These are only broad guidelines and only for initial settings. Then you monitor the patient, see what's happening, and then take a decision from there on. And anyway, while setting the tidal volume, we have to maintain Plateau pressure of less than 30 centimeters of water, which we'll discuss when we discuss lung protective strategies. In some cases, it may even be necessary to let PaCO2 rise a bit and pH fall outside patient's normal values because you don't want to injure the lungs. Okay. Ventilator-induced lung injury is something that we can avoid or prevent. Okay, for setting the pressure control value, the initial example I told, I empirically put a pressure control value of 10. Another way is to deliver a volume targeted breath. Now you know approximate tidal volume that you are targeting. Then with the desired tidal volume, you measure the Plateau pressure baseline values and then get a pressure value from that. Using some baseline, same baseline pressure, breath can be switched to pressure targeted breath using a set pressure which is equal to the Plateau pressure, not the peak pressure. Again, to remind you, in a volume targeted breath, you can get a peak pressure. The highest pressure attained is peak pressure. Then you give an inspiratory hold. It comes to an equilibrium. That is the Plateau pressure. So you target this as the pressure control value for your initial settings. Okay. A word about how body weight and tidal volume are related. You can see two different persons of the same height. Do you expect a more obese patient to have a broader heart and broader lung? No, it doesn't happen like that. So don't take that body weight, actual body weight is an indicator of the degree of size of the lung or heart. It is important to understand that the adult's lung do not get larger as he or she gains weight. So we can go for ideal body weight or predicted body weight. You can have a rule of thumb to calculate the ideal body weight. For males, it will be 50 kg plus 2.3 kg for every inch over 5 feet. And for females, 45.5 kgs plus 2.3 kg for each inch over 5 feet. You can always measure the length or height of the patient if you have a simple instrument called measuring tape in your ICU and emergency room. Many people are worried about tubing compliance. Compliance, as we discussed the other day, is the distensibility. The breathing circuit is also distensible. So the tubing compliance reflects the volume in mLs of gas compressed in the ventilator circuit for every centimeter of water pressure generated by the ventilator during the inspiratory phase. Again, the formula is same, delta V by delta P. Usually our ventilator circuit distance, the compliance is around 1.5 to 2.5 mLs per centimeters of water. So what is the implication? When the machine tries to push the gas into the respiratory system through the endotracheal tube and other devices, the circuit also tries to expand and accommodate a little bit of volume. So that is the problem with the breathing circuit compliance. But luckily for us, the current ICU ventilators have the capability of measuring and correcting for tube compliance. So during startup tests of the system, these ventilators calculate the compressibility of the ventilator circuits, and even operator can choose to use this correction or simply ignore it if you are doing ventilation on an adult patient. A slight change in tidal volume may be insignificant for an adult, but it can be critical for an infant during mechanical ventilation. Such cases, we need to take into account tubing compliance as well. Another factor that can be misleading is mechanical dead space consideration. The moment you put an invasive device like endotracheal tube, actually we are reducing the anatomical dead space by probably maybe 100 ml or so. But again, the circuit, the apparatus dead space, the components of the breathing circuit, including the endotracheal tube, HME, and the components up to the Y-piece, where the inspiratory and expiratory limb meet, that actually adds to the dead space. Again, while doing mechanical ventilation, you have to always think about the physiological dead space, because physiological dead space is where ventilation may be happening, but gas exchange is not happening, because it happens always with a diseased lung. So these factors may be playing around. As I said in the other day, ventilation, the CO2 washout depends on the alveolar ventilation, not the minute ventilation. Anyway, for initial settings, you can forget about these things, but you get a blood gas, give an idea about the PO2, PaCO2. Take these values also into consideration and then do the adjustments thereafter. How do you select FiO2 or fractional concentration of oxygen? The goal of selecting a specific FiO2 for a patient is to achieve a clinically acceptable PO2, which is around 60 to 100 millimeters of water, millimeters of mercury. Titrating FiO2 using pulse oximetry and ABG findings can minimize the risk of administering too much oxygen. Most of the time we start with 100% oxygen, then looking at the SpO2, if it is maintained about 90 to 94% or above, you can reduce the FiO2 by 10% or some cases 10 to 20% at a time and see for the trend. And once you stabilize, get a blood gas and see the value, how much you can come down to. The desired FiO2 is given by PaO2 desired into FiO2 non-factor, PaO2 non. That means if you take an FiO2 of 80%, you get a FiO2. You know the desired PO2, somewhere you can set between 70 or so. Then you will get the desired FiO2, assuming that the lung condition doesn't worsen during that time. Okay. So your idea is to reduce the FiO2 as much as possible, but definitely during your airway manipulation, disconnections, you make sure you give additional FiO2, especially when you are doing some procedures like endotracheal tube suctioning. And this is the settings by another doctor for our same patient on case 1 after post-cardiac arrest patient. This time he has gone for assist control volume targeted mode. How do you rate it? So you look at the monitor, FiO2, yeah. But you see PEEP is 3. Okay, set PEEP is 4, but it's around 3 to 4, which may not look suitable for a clinician when the patient is in pulmonary edema. Okay, again, you look at the vitals. The question is whether you are happy with the oxygenation. Okay, if patient is not at all in pulmonary edema, lungs are preserved, not flooded at all, then probably a 5 centimeters of water PEEP might do. Okay, how does PEEP help in oxygenation? We'll come to that. And again, you have to be cautious with PEEP because in a congestive heart failure, you need to maintain the hemodynamics as well. So the PEEP can adversely affect hemodynamics if the PEEP value set is higher. So PEEP helps to improve oxygenation. Okay, it causes increased mean airway pressure and intrathoracic pressure, leading to reduced venous return, which can reduce the preload to a failing heart, thus improving its function. PEEP reduces the work of breathing and reduces the myocardial work. PEEP may allow sufficient time for the pharmacological treatment to become effective. We are keeping the lung units as much open as possible to expose maximum alveolar surface for gas exchange, so that by the time your diuretics and other drugs will drain away the excess water and reduce the lung congestion, we can maintain oxygenation. So that is the idea. Suppose you want to do ET suctioning, the best thing is to use closed suction. Okay, most of the newer ventilators give you direct instruction how to start closed suction. You can activate the suction mode from the menu. The FaO2 will go to 100%. You press the play button, then during this time, you can do the suctioning and then start with the positive pressure. After every bit of negative pressure application, you have to do some recruitment also. Okay, that is with regard to doing procedure, especially when PEEP matters most. Again, during your initial ventilator settings, alarm settings are also important. So you need to be familiar with your equipment, how to keep the alarms. So these are the broad guidelines. Alarms are audible, visible alarm systems designed to alert the clinician of potential dangers related to the patient-ventilator interaction. Okay, there are different levels, 3 different levels in fact. Level 1 is immediately life-threatening. The color code is red. It happens when there is electrical power failure, no gas delivery to the patient, or any exhalation valve failure. These are imminently life-threatening, and you cannot simply ignore at all. Level 2 alarms are potentially life-threatening. It happens during circuit leaks, circuit partially obstructed or kinked, HME malfunction, inappropriate settings, inappropriate oxygen level, or gas blender failure, or inappropriate PEEP or CPAP level, too low or too high. So different manufacturers will have a different coded, audio coded also. Some machines will give series of 3 tones. So these alarm messages are also color coded, so you will know the priority level also. Level 3, not life-threatening, but a potential source of patient harm, like changes in lung characteristics, like compliance or resistance, very high respiratory rate, development of auto PEEP beyond a particular level, etc. These messages or alarms should be color-coded with the blue. Okay, how do we set? You know how much is the pressure control required. Low pressure alarms are usually set around 5 to 10 centimeters of water below the peak inspiratory pressure. So this will help you to detect disconnections or leaks in the system. High pressure alarms are set usually about 10 centimeter above the initial peak pressure observed. So usually will end the expiration when activated. Low PEEP or continuous positive airway pressure alarms usually set about 2 to 5 centimeters of water below the PEEP level. And apnea alarm period 20 seconds is the highest accepted maximum. The biggest problem in our ICU is the junior doctors or staff members getting tuned to the music of these alarms, and they try to disregard or ignore these alarms. This is not a practice to be supported at all. Every case you need to have sensible limits set in your machine, so that whenever the limit is exceeded, you get alerted, you do something to avoid that alarm coming again. Low source gas alarms alert the operator that the available high pressure source is not functioning. So this alarm is critical for newer microprocessor ventilators that rely on high pressure gas to function, particularly for ventilators that do not have a built-in compressor. Low exhale tidal volume, usually we keep 10 to 15% below the set tidal volume. Low exhale minute volume, again 10 to 15% below the average minute volume expected. FaO2, the oxygen sensor alarm, usually 5% above and below the set oxygen percentage. And what to do during ventilator alarm situations? First, ensure that the patient is being ventilated. When in doubt, the practitioner should disconnect the patient from the ventilator. Start manual ventilation using a manual resuscitation bag. Then silence the alarm. Call for help. Sometimes there will be a malfunctioning of the equipment as such, which might require your hospital biomedical or technician to come into the scene, and probably it might require service or major interventions. In such case, you keep the ventilation going using a manual resuscitation bag and try to get a different mechanical ventilator for your particular patient. We'll take one more scenario to discuss how you set the initial settings. Here there is a 22-year-old lady brought to emergency room with impending respiratory failure at early morning 3 a.m. There is history of severe persistent asthma. She is already cyanotic, anxious, but her breaths are labored in spite of bronchodilator therapy and steroids. Now she is transferred to the ICU. The decision is made to intubate and begin mechanical ventilatory support. How do you do the initial settings? Here the volume control or pressure controlled mechanical ventilation modes are acceptable modes immediately following intubation. The peak pressures, you have to expect it to be high due to very high resistance because of the severe bronchoconstriction and the resistance along the tracheobronchial tree and the use of high inspiratory gas flows. So you need to get ready to face a peak pressure of maybe 50 or 55. But you make sure that the alveolar pressure, that is the Plateau pressure, should be less than 30 centimeters of water despite very high peak inspiratory pressure. Again, FiO2, you can be liberal. You need to give a PaO2 of something around from 60 to 100. Usually, we might require a FiO2 of 0.5 and above. You start with 100% oxygen, try to come down, and then see the situation. This is what I was referring to. This phase, the difference between peak inspiratory pressure and plateau pressure is all accounted by the increased airway resistance. This much pressure drop is actually lost in the work of overcoming the resistance through the narrowed or constricted airways. But as long as the plateau pressure is within the normal limit, less than 30, then you are not going to have barotrauma risk. But of course, these patients with emphysematous changes or chance of bullary rupture and all, you need to anticipate pneumothorax incident, but you can keep monitoring for that. But for the time being, keep the plateau pressure in check, and then you need to accept a higher peak pressure until and unless your bronchodilators, your other mechanisms to control the primary trigger like antibiotics, sepsis control, when these work for the patient, then this gap will definitely come down as the exacerbation is controlled. One more thing, after connecting, you can look for a maximum CO2 washout, but permissive hypercapnia, you have to accept it as long as pH is acceptable. You may have to tolerate with a higher PaCO2, because if you go on a very high minute ventilation, this is what can happen or what you might see on your ventilator monitor. Here you can see this is the flow diagram. Okay, this is the exhalation phase. The exhalation, this is not coming back to the baseline. Okay, so that means there is air trapping happening. What is air trapping? That is inadequate exhalation. That will cause some air to be retained from the previous breath when the next breath comes. So this will cause intrinsic hyperdynamic inflation. So this is something to be avoided if you want to treat it. How to treat it? You can simply allow more exhalation time so that this exhalation flow curve returns to normal. Okay, so here the prolonged expiratory phase is the allowance we give so that there will be less of air trapping. This will spring in two terminologies, like something called intrinsic PEEP or auto PEEP. Auto PEEP is something automatically generated or by default generated. PEEP is positive end expiratory pressure. So intrinsic PEEP is something which develops, or positive pressure that develops because of inadequate exhalation. Okay, so this is how it happens. Inadequate exhalation, some amount of air is retained in the alveolar units, so there will be air trapping leading to auto PEEP. Okay, so auto PEEP or intrinsic PEEP, incomplete exhalation prior to the initiation of the next breath. There will be progressive air trapping and dynamic hyperinflation. So the curve will, monitor will show like this. Okay, the exhalation flow curve is not returning to the baseline. By that time, the next inspiratory flow happens. So this can lead on to reduced venous return, reduced cardiac output, and potentially cause hypotension, especially if your patient is volume depleted. So this effectively leads to alveolar overdistension. It will lead on to pulmonary barotrauma, ventilator-induced lung injury. The V by Q mismatch increases because the hyperdynamic hyperinflation will compress on the capillaries, further deteriorating V by Q mismatch and leading to hypoxia. So you have to avoid it by giving better expiratory time. It's not the higher minute ventilation. Okay, high minute ventilation may be the culprit. It's not the high tidal volume or high rate. What we require is high expiratory time. That's when we are worried about the IE ratio. Okay. The causes of auto PEEP, it can be high minute ventilation, expiratory flow limitation, as in our case, bronchospasm, inflammation, and remodeling, or even there may be expiratory resistance because of the narrow diameter or kinked endotracheal tube, inspissated secretions, exhalation or PEEP valves, and patient ventilator asynchrony. These are the other causes of auto PEEP. How do you manage auto PEEP? You focus on determining and treating the underlying cause. The bronchodilators, steroids, and antibiotics. Duration of expiration should be prolonged by decreasing the tidal volume, decreasing the respiratory rate, and increasing the inspiratory flow, because your inspiratory time percentage is going to, proportion is going to be reduced. So go for a higher inspiratory flow. So this management may require sedation, pharmacological paralysis, or replacement of the endotracheal tube or ventilator tubing. The role of applied PEEP. How do you, over and above that, you also apply PEEP. How does it help? Applied PEEP hold open the narrowed airways during expiration, improving the expiratory airflow and allowing more complete expiration prior to the onset of next breath. Applied PEEP should be always less than the measured auto PEEP, maybe 50% or 2/3 of the auto PEEP as per different authors. You need to understand what is time constant to plan your expiratory time. I think last session somebody asked about time constant again. It is measured in seconds. It is the product of compliance and the airway resistance. One time constant is the time required to fill or empty 63% of the lung unit. Okay, the higher the airway resistance, you need more time constant. The time constant will be higher. So you need to set the inspiratory and expiratory rate with more than, our expiratory rate should be more than 3 time constant to allow adequate exhalation or acceptable exhalation and to reduce auto PEEP. One example of time constant calculation here, the machine gives you the resistance value and compliance, that is the static compliance. There is something tricky about it. The time constant is the product of compliance and the resistance. Here the compliance is in mLs per centimeters of water. So compliance is 60 ml per centimeters of water, but resistance is in liters per second. So you need to convert this into liters. Okay. So the compliance here is 0.06 liters per centimeters of water. Resistance is 10. So the time constant comes to 0.6. So you make sure that the expiratory time allowed as per your planned IE ratio should be at least 1.8 seconds or more to allow adequate exhalation. Other guidelines for asthma: if the ventilator settings cannot accommodate the patient's need, the use of sedatives and paralytics may be necessary. The use of sedation and paralysis may permit use of resting of fatigued respiratory muscles, particularly during the initial few hours. All you do is buy time to tackle the triggering event, that may be sepsis, by your antibiotics and other bronchodilator measures. There was again a query on rise time PRAM. So this is the graphic. I think last time also we have shown this. The RAM is the inspiratory rise time, determines the rate at which the ventilator achieves the target pressure. The first curve you can show, it's a slow rise. It takes some time to achieve the target pressure. Next is moderate rise. By almost half this time, it achieves the target pressure, and fast rise is when it's almost instantaneously achieves the target pressure. So ramp time you can set either as the percentage of breath cycle time or in seconds. Okay. Some manufacturers or proprietary term is P-ramp, otherwise rise time. Okay, these are the different slopes or curves. This one fast ramp, intermediate and slow rise time. Okay. Now, after connecting the patient to the ventilator, you have to keep monitoring the values given on your screen. Eyes won't see what mind doesn't know. So you need to decipher or interpret each and every value appearing on your screen. Each number is important. Here you can see the graph, the scalars. The scalars are graphs plotted against time. Okay, you can see the peak pressure, plateau pressure, minute ventilation, tidal volume, spontaneous ventilation characteristics. These are the set parameters. These are the monitored parameters. These are the scalars and loops. Scalars are a graph against time. Loops, you connect two different variables, maybe pressure volume or pressure flow, so that you will get to interpret from the shape of it. Okay. So these are the flow curves. Only the flow curve will have a negative swing in the graph. All others are tracing on the positive side. Okay. So there are different uses. Flow curve will give you auto PEEP. You can identify the mode. You can pressure tracing. You can get the peak pressure, plateau pressure, driving pressure, compliance, volume. You can identify the leaks. Okay. The types of breath we have explained in the first session. You can identify that this breath is triggered by the machine, limited by the machine, and cycled by the machine. So this is a controlled breath. Here you can see a negative side deflection, which initiates. So this may be an assisted breath. This is flow limited and volume cycle. Here again, there is a trigger, and then it's pressure limited and time cycle. Here you can see the flow curve touches the baseline before or at the time of cycling. In pressure support, what happens is the flow is not touching the baseline at the time of cycling. I'll explain that again. This volume versus time scalar gives you the leak and the tidal volume attained. This difference is the air leak. This is regarding the pressure support ventilation, how cycling occurs. Here actually the maximum flow rate, if you can put it as 100% of the maximum, when it comes to 75%, 50%, and then 25%, when the expiratory trigger sensitivity is kept as 25%, then the exhalation valve is open and the phase goes to expiration. Now, if I change the expiratory trigger sensitivity to 50%, what happens is, by the time the flow reaches 50% of its maximum value, it cycles. So what happens here is effectively the expiration time is prolonged. Otherwise, pressure support ventilation is initiated by the patient, limited by flow, and then cycled by flow. Okay. This tracing you already explained regarding peak pressure, plateau pressure. The difference between peak and plateau pressure is high when there is a high airway resistance. If the plateau pressure itself is rising, that means the compliance is low. We are dealing with a restrictive issue, maybe ARDS or pneumothorax or severe pneumonia. Again, your screen, you can see the loops like flow volume loops. You can identify the different parts. Peak expiratory flow rate, this is the FRC value, this is the inspiration. Sometimes you'll get sawtooth appearance like this, which will show that there is water trapping, and scooped out appearance shows that there is severe obstructive lung disease. So all these can be interpreted from the graph itself. I'll take a few questions quickly from the previous questions. Chat, right out of the chat box. What is a supported breath? Supported breath is actually initiated by the patient. Okay, then maybe limited by the ventilator and cycled again by the patient. Assisted breath is initiated by the patient but limited and cycled by the ventilator. Types of ventilators, somebody asked, there can be different kinds of answers, maybe negative pressure ventilators, which are non-existent these days, positive pressure ventilator, or you can categorize it like ICU ventilators, anesthesia ventilators, transport ventilators. or you can classify like manual bag resuscitate, Rambo bag as a manual ventilator, and other mechanical ventilators. Okay, so there are different kinds of classification available. It depends on which source the examiner or the person is referring to. Scalars and loops I have already explained. Do we compensate for volume expansion of the circuit attached for adult cases? Not much, because your pre-use checklist itself, the machine will calculate the tube compliance. Even if you ignore it, doesn't matter much as long as you are not ventilating a neonate. What do you, which mode do you think need less sedation, and whether you use relaxant? Our idea is to keep the patient passive. So most of the newer modes we'll discuss, and the sedation requirement we'll be discussing along with that. Regarding relaxants, the present trend is to reduce the use of relaxants to the minimum, and maybe monitor the neuromuscular blockade as and when you start on relaxant. But the lesser the amount of relaxants you use, better it will be for the long-term outcome, because your critical illness neuropathy and other complications and prolonged ventilation issues will be far lesser if you can keep the patient passive by addition of additional opioid or deeper sedation. Head injury or postoperative patient of head operation, PEEP should be 0. Is it true? PEEP actually should be used cautiously in patients who have intracranial anomalies, or when you are speaking about unilateral or focal lung diseases, when the patient is having hypotension, hypovolemia, pulmonary embolism, or dynamic hyperinflation without airflow limitation, or even in the case of bronchopleural fistula. High PEEP might cause venous congestion and raised ICP. It may also have undesirable consequences in patients undergoing prone ventilation, because whichever way high PEEP is going to help you may work the other way when you try for prone ventilation. In modern era, 0 PEEP is usually used only for patients in severe bronchospasm, in severe exacerbation, that too when the patient is passive and paralyzed. Otherwise, present day, not many people advocate for 0 PEEP. Triggering mechanism in assist control mode. Quick revision. I think there are two kinds of triggers: flow sensor trigger or pressure trigger. There is a continuous flow, delivered flow from the machine, and the machine will check for return flow. When the patient tries to attempt a spontaneous breathing, the return flow reduces. Okay, so to compensate for that, machine will sense, and the bias flow gradually increases, and then machine proceeds to give an assisted breath. When it comes to pressure triggering, when the pressure tracing comes down, maybe if you set -2 centimeters of water from the baseline, if it is pulled down to -2, then the next breath is assisted breath is triggered. Usually flow triggering, we usually keep 2 liters per minute for flow trigger. Difference in SAME, pressure controlled and volume controlled by graph, we have already explained. And volume controlled, usually you get square wave pattern flow, usually we get. Okay, I think one of the person asked whether decelerating flow pattern is acceptable in volume control. Yes, some of the manufacturers allow to use a decelerating flow pattern also, but the change is, here in a constant flow, you can have an inspiratory pause and your plateau pressure you can get. In a decelerating flow pattern, it may not be that much reliable. Otherwise, there is not much point in the type of flow pattern. Okay, that's what I understand. Pressure modes, the decelerating flow pattern is usually used. You can see the volume touches the maximum and then waits till the cycling occurs. So this is the typical pressure tracing. Depending on your rise time, the pressure value rises to the set pressure and then maintains till the cycling occurs. Okay, in volume control mode, I have already explained, can we have flow descending in descending mode? Yes, some of the ventilators will allow to change the flow pattern.